part 2 of the video. So getting back to the micronutrient and heart disease. Another thing that is not helpful is to have high levels of oxidative stress. Okay, this is where taking your antioxidants would come in to help with that. So vitamin C and vitamin E help blood vessels to maintain their flexibility, allowing them to easily dilate and contract. A powerful antioxidant, lipoic acid, reduces blood pressure by inhibiting inflammatory response in blood vessels. Vitamin D deficiency is linked to hypertension. So vitamin B6, B12, folate, serine, and choline are necessary to help our body metabolize homocysteine and reduce the risk of arterial scarring. In fact, B vitamin therapy has been an effective treatment for reducing heart disease and blood pressure. Okay, keeping your heart strong. So the heart requires a lot of energy in order to work. Carnitine is an amino acid that facilitates the transport of fatty acids into heart cell mitochondria. So that's what helps keeps the heart, as far as fuel is concerned, it's an ingredient that helps. Vitamin B1 helps with metabolism. People with congestive heart failure are very deficient in vitamin B1. And coenzyme Q10 is required by cardiac tissue. Statin drugs, so high cholesterol medication, deplete the body of CoQ10. So deficiencies of CoQ10 in statin users are particularly common. The side effects of statin therapy is usually muscle pain, right? So we have skeletal muscle and cardiac muscle, and they feel that, the CoQ10 deficiencies. Okay, heart disease is an inflammatory process. Okay, so that is the more modern way of now talking about heart disease. It's inflammation. So scientists now emphasize that heart disease is actually an inflammatory condition. Inflammation and oxidative stress work together to damage the arteries. So as you can tell, if you only treat the LDLs, which are known as the so-called bad cholesterol, you're actually not getting to the underlying process, right? You're not getting the underlying condition. The underlying condition is inflammation, nutritional deficiencies, oxidative stress, and diet and lifestyle things, okay? So once you start to fix that, then the heart can either heal itself depending on where they're at in the disease process, or you're preventing a future problem. Glutathione is the most potent antioxidant in the body, okay? And that's something you can take. Glutathione, B12, selenium, vitamin E, vitamin C work together to reduce oxidative stress throughout the entire cardiovascular system. Okay, this is a very reputable lab company that I use called SpectraCell Labs that gets into advanced clinical testing. So I will order a full panel on people and then send the blood to the SpectraCell Labs, look for the results, and then we go over appropriately what needs to be done to help this patient turn over a new leaf. Either avoid heart disease, try to reverse it, or both. Okay, based off of blood chemistry. Okay, more on the medication that you're on, the nutritional deficiencies that it causes, and then the potential health problems. Okay, again, I'm not going to go over this verbatim, but if you were a patient of mine and you were taking NSAIDs, then we would dive in and be very specific on what this is causing. Okay, if you were on diabetic medications, And I do this because I want people to understand that you cannot expect to be healthy if you're deficient in nutrients that actually help your heart. All right, on this one, this is a review of some of the tests. So you can run your lipid panel on your patients, and that typically includes your LDL, HDL, triglycerides, total cholesterol, and sometimes VLDLs. Whoops, VLDLs are on there. Okay, that's a classic lipid panel. What's better is to add the VAP test or the LPP test, so lipid particle protyle test, and that's what we wrote down earlier with the most atherogenic one, the LPA, and a ApoB. Okay, so these are some examples of these subparticles of cholesterol that people can have. Okay, you can also do a stress test. This evaluates the heart. So basically exercise and EKG. So you're hooked up to all the different leads and you're put on a treadmill or a Stairmaster, and they're elevating your heart rate to see what the EKG looks like. So that's a stress test. Very good test to look at heart stuff. Okay, then there's an angiogram. Okay, where they put essentially a type of dye in the coronary blood vessels, and they take an image of it to see if there's any blockage. Okay, here's an example of an angiogram where essentially a dye is put into the coronary blood vessels. Here's one where you could see the blockage, and that's before the surgery, and then here is after. Okay, likely put a stent in to open up that blood vessel, or maybe rotor-rooter it out. Here's another angiogram. Looks like the circumflex artery of the heart, coronary artery. But here's the, it picked up on the blockage, right? So, and then here's your repair. Okay, so angiograms, it's a good study, lets you know if there's any blockage going on. Okay, now we do have the technology, if a person does have heart blockage, to intervene and help and save lives. I mean, I think that's amazing. Of course, I don't want people to get to that phase. So I'm big on preventative care. How about let's not have to have heart surgery? However, if for whatever reason a person gets the coronary artery disease, then we certainly have some amazing technology this day to help people overcome their heart injury. Okay, so that was some pictures on an angiogram. Okay, another test you can do is a C-reactive protein. Okay, this is an inflammatory marker that's done through blood labs. Okay, ACS, or acute coronary syndrome. Okay, this is unstable angina, or can be called an MI, a myocardial infarction. Okay, normal is this nice open lumen. Okay, and what happens is the lumen gets all clogged up. Okay, so it is now a blocked lumen, which decreases oxygen, which decreases ATP. Okay, ATP is our fuel. Okay, so no fuel, heart cells die. And when that happens, it's either an MI, angina pectoris, or arrhythmias. Okay, so the hospital is going to run some heart tests. So CPK is one of them. That stands for creatine phosphokinase, or CPK. It's an enzyme. Okay, it ends in an ACE, so it lets you know it's an enzyme that's found in heart muscle. Okay, it's also known as simply creatine kinase, and it indicates something. So tissue would be that something is being destroyed. It's also an inflammatory marker. CKMB, right? CKMB is the creatine kinase enzyme found specifically in heart muscle. Okay, now my understanding is a lot of clinics are starting to move away from testing CKMB, but it's still a test that can be run. Okay, another one is troponin. Okay, troponin is a protein that is usually released in the blood with an MI. Okay, the different troponin heart markers are troponin I and troponin T. Okay, troponin I and troponin T. Troponin I is the worst to have between the two. What happens is when the heart gets hurt, it releases this protein into the bloodstream, so you can pick up on that. Okay, myoglobin is an oxygen binding protein found in the heart. So it's found with heart damage and is released into the blood. Okay, this test is ordered if there's a suspicion of a heart attack, or if there's chest pain, shortness of breath, symptoms of coronary artery blockage. Okay, an EKG would be abnormal. Now, obviously, people come in with chest pain and stuff like that, and it's something else. I mean, it could be a rib fracture, it could be something else. So an EKG could be normal, but in this case, if there is a heart issue, likely an EKG will be abnormal. Okay, oxygen will be low. Blood pressure is usually increased. However, at times it can be too low. Pulse is diminished. They'll certainly be experiencing chest pain. So angina pectoris is a fancy word for chest pain due to ischemia or intermittent decreased levels of oxygen being delivered to heart tissue. So it feels like an MI. So people go to the hospital as a result. Referred pain can be up to the jaw, the neck, especially the left side of the neck, shoulders, left arm, left hand. Okay, spine, usually in between the shoulder blades and the back. Okay, these are referred pain patterns for heart issues. Okay, ACS or acute coronary syndrome is caused by ischemia due to atherosclerosis, plaque rupture, or clot formation. All right, all this will cause unstable angina. That feels like they're having an MI, myocardial infarction, or heart attack. Okay, an MI is cell death due to decreased oxygen. Diagnosis requires 3 key things. Okay, number 1, the signs and symptoms of the patient. Number 2, EKG changes. And the third thing is increased blood markers. Okay, the ones, so this is done through labs. So the ones we talked about before, such as CKMB, troponin, myoglobin, and all that stuff. Heart cells and heart tissue changes because of MI. Okay, day 1 through 7, there is edema. Okay, coagulation necrosis, increased white blood cells at the site. Okay, other tissue changes is after an MI, so days 7 through 60, there's granulation. Which essentially is scar tissue forming and increased collagen deposits. So the collagen is the scar tissue. And then day 60 and on, dense collagenous scar tissue sets in. Okay, by the way, this type of scar tissue is not able to contract very well. Okay, injury and ischemia will show on an EKG. By S to T segment changes. Okay, let's do a quick review of the EKG lettering. So it's P, Q, R, S, and T. And I do prefer you write it this way because it keeps everything in order. So P is atrial depolarization. The QRS complex is ventricular depolarization, and the T is ventricular repolarization. Plus, when you say things like S to T segment changes, you can visualize S to T segment changes. Okay, the S to T segment would be elevated, an elevated wave. So here's a reminder of normal EKG. Okay, so we have, there's your P wave, followed by QRS, then followed by the T wave. And then this whole cycle would repeat and then keep repeating and keep repeating. Okay, so on your EKG strip, it would look something like this. Here's your P wave, and then QRS, followed by the T wave. And then it would start over. P, QRS, and then T wave. And then it would start over, and so on, okay? So tachycardia would look like this. Okay, you can see the time intervals are going to be different. And then bradycardia would look like that, so just slower. You're still going to get your P, QRS, and T wave, but the time in between is going to be slower. And then here's irregular. Okay, so different intensities. So if you compare this QRS to that one, here's a change in the T wave versus this T wave. Okay, so these are just reminders of your EKGs. All right, here is an example of the S to T segment that is elevated. All right, so here is P, Q, R, S, and then your elevated S to T. Okay, elevated S to T, elevated S to T waves. All right, if we were to draw that out, then it would look something like this. So here is the initial P wave, followed by Q, R, put on the S, going to keep it elevated. Okay, so here's our elevated S to T segment. All right, the S to T indicates an ischemic injury. Treatment is stat, so right now, to improve perfusion. to improve perfusion and oxygen to tissue. The S-T wave is between ventricular depolarization and ventricular repolarization. A 12 lead EKG is used. Usually an increase in the Q wave and an increase in the S-T wave would mean an injury to the left ventricle. Now keep in mind, the left ventricle, when it squeezes, pushes blood to entire body. Okay, that right ventricle just sends blood to the lungs, but the left ventricle sends blood to the entire body. Okay, MI treatments are variable due to the severity of the case, age of the person, pre-existing condition. Okay, you have an increased heart and tissue, oxygen to tissue, so that's one of the goals, and to decrease the myocardial workload. Okay, you want to improve the preload and afterload. Reducing these can be difficult. You also want to control heart rate, offer pain relief, and then the medications can be things like sympathetic antagonists. Okay, now keep in mind, sympathetic is your stress, which means it can increase heart rate and increase blood pressure. So you're actually trying to block that stress. So sympathetic, antagonistic medication, nitrites, morphine, antiplatelet therapy, thrombolytic drugs. An angioplasty may need to be done. Stents, coronary artery bypass grafting, simply known as a bypass surgery, and reperfusion therapy, which is opening the coronary arteries. Here's an example of what a single bypass would look like. Okay, there's the single tube. A double, so there's 1 and 2. Okay, a triple, so there's 1, 2, and 3. And then here's a quadruple, 1, 2, 3, and 4. Okay, so sometimes you'll hear things like I had a double bypass surgery. The fancy way of saying is coronary artery bypass grafting, or just simply bypass surgery. So they're bypassing the clogged area. So for example, if this is the tube that has the clogged area, then they would simply do the bypass. They're bypassing the hurt area. All right, a decrease in myocardial perfusion can give you partial ischemia, or total ischemia. All right, partial ischemia, you're going to get a decrease in ATP, which means a decrease in heart contractions, ions will leak Okay, remember ions are positive and negative charges. And when you get ions leaking, you get S to T changes, and you get dysrhythmia. In total ischemia, there is no ATP, so therefore no oxygen and no contraction. No electric potentials. And either a flat line or Q waves on EKG. There'll be an increase in CKMB, increase in troponin, I or T. I remember I is the worst one to have. And so either a flat line on EKG or nothing but Q waves. Okay, an MI. Oh, here's some of your surgery options for a clogged heart artery. So thrombolysis, so an enzyme medication is given to go in there and try to break down the plaque buildup. Okay, there's the physical disruption of the plaque, so that's your whole roto-rooter thing, or pure percutaneous transluminal coronary angioplasty, or just simply an angioplasty. A stent can be put in to open up the diameter of the tube. And then there's your bypass, coronary artery bypass grafting, where they simply bypass the hurt area. Okay, an MI will cause a decrease in stroke volume, increase in fluid retention. So consider venoconstriction of the kidneys, which will increase the preload, which will increase the ventricular wall tension, which will increase in hypertrophy of cardiac myocytes. Okay, sudden cardiac arrest, or SCA, is cardiac tissue death within 1 hour of symptoms. CPR is used, usually significant fibrillations are occurring with sudden cardiac arrest. This is where defibbing comes into play. Myocardial atrophy. Heart experiences scar tissue, and this can cause an SCA, okay, or sudden cardiac arrest, and electrolyte imbalances. Okay, chronic ischemia cardiomyopathy. All right, chronic is letting you know it's been there a long time. Ischemia is deprivation of oxygen. Cardio is heart. Myo is muscle. And pathy or pathology is a disorder of. So this says heart failure due to progressive, long-term deprivation of oxygen over time. Heart cells die slowly over time. Okay, endocardial valve disease. So this is caused by some form of inflammation that causes scarring, calcification, and malformations. Okay, the valve can experience stenosis. Okay, keep in mind we have 4 valves in the body. You have the 2 semilunars and the 2 AV valves. So pulmonary semilunar valve, aortic semilunar valve, and on the right side of the heart, the tricuspid valve, and on the left side of the heart, the bicuspid valve, also known as the mitral valve. Okay, so these valves can failure to open up completely. It's usually a slow process. Regurgitation is the inability of the valve to close. And then a murmur is a result, which is a result of the turbulent changes. Okay, so if the valve has the inability to close, then you're going to get backflow of blood, and that backflow causes a swishing sound. So the backflow is regurgitation. The swishing sound is the murmur. Okay, mitral stenosis. The left AV valve. So the mitral valve is also known as the left AV valve, which is also known as the bicuspid valve. Okay, the stenosis can impair blood flow. So stenosis means the opening is getting smaller, so it's stenosing or getting smaller. Okay, left atrial pressure increases, then left ventricle pressure increases throughout diastole. This can increase left atrial size. This can also hurt the lungs by increasing pulmonary pressure. Now, the reason why the lungs is because you have to go back to blood flow through the heart. So from the lungs, okay, blood travels through the pulmonary veins and enters into the left atrium. Okay, so if the left atrium is hurt, then that can create backup. So then you have to visualize this blood flow backwards, which means eventually the lungs can get hurt. Okay, this is chronic pulmonary hypertension. So there can be a decrease in stroke volume, which increases a person's heart rate. Okay, signs and symptoms, orthopnea, which is discomfort while breathing, cough, dyspnea, or labored breathing, abnormal breath sounds, and exercise hurts. Okay, mitral regurgitation. This is backflow of blood from the left ventricle into the left atrium. Okay, in order to know that, you'd have to know blood flow through the heart. So from the lungs, blood enters into the left atrium through the pulmonary veins. And then from the left atrium, that blood will spill into the left ventricle, going through the bicuspid valve. Also known as the mitral valve. Okay, signs and symptoms are similar to mitral stenosis. Rheumatic heart disease can cause mitral regurgitation. Okay, rheumatic heart disease can come from, or I should say a side effect, from inflammation due to infection, such as scarlet fever, strep throat, okay, strep throat is caused by the strep pyogenes. Okay, also known as gas or group A strep. Okay, so that bacteria gets inside and causes endocarditis, and the valves are considered part of the heart endocardium, so therefore it can cause valve problems. Okay, so rheumatic heart disease. All right, mitral valve prolapse. Mitral valve balloons into the left atrium. Okay, it's similar. Signs and symptoms are similar to mitral stenosis. Okay, there's your mitral valve. And here is the left ventricle area. So that makes this the left atrium. And there is a prolapse. Okay, so a ballooning of the valve into the left atrium. Okay, like you can see there. Aortic stenosis is narrowing of the aortic valve. Infection can cause this. Age-related calcification can cause it. So as we get older, the aorta can just simply calcify. Rheumatic fever, this usually occurs in youth. Okay, so this injury is usually a youth thing. Decreased left ventricle flow into the aorta, and an increase in left ventricle systolic pressure. Okay, here's a picture of that. So here is a normal aortic valve, nice and open. Okay. And then when it's closed, it's sealed off, so fluid can't get through. But with stenosis, because of calcification and whatever, it does not open all the way, and it cannot close all the way. So there's still some opening left, even when it's supposed to be closed. Aortic regurgitation is backflow from the aorta into the left ventricle. The left ventricle can then experience hypertrophy, okay, which means it enlarges, the left ventricle enlarges. And a murmur can accompany this. Signs and symptoms: a pounding heart, throbbing heart because of increase in stroke volume. Okay, rheumatic heart disease, consequence of rheumatic fever. About 15 million people worldwide get this. It's acute inflammatory disease from group A, beta hemolytic, strep. All right, another risk of this is the destruction of red blood cells, thus the word hemolytic. Okay, treatment would be antibiotics. Okay, signs and symptoms of rheumatic heart disease would be joint pain, truncal rash, fatigue, chorea, which is abnormal jerking movements, tachycardia, pink ring, or lines on the skin. All right, different myocardial diseases. Okay, one is myocarditis. This is inflammation of the heart muscle. Okay, so myo is muscle, cardio is heart, and itis is inflammation of. Okay, this can lead to necrosis, okay, degeneration of heart muscle cells, and the cause is usually viral. Okay, cardiomyopathy is usually genetic, or it can be genetic or acquired. Okay, this is a non-inflammatory response, also considered an insidious. Okay, an insidious onset, which means you have it, but we don't know exactly why this serviced. Okay, cardiomyopathy, there are three types. There's dilated, hypertrophic, and restrictive. Okay, dilated, all four chambers are enlarged. Okay, meaning so if we take the heart and we create our four chambers, okay, all of them are increased in size. Okay, then there's hypertrophic, and then restrictive. Okay, hypertrophic is going to be just that left ventricle enlarged. And then restrictive, there's actually stenosis that occurs. Okay. Okay, so restrictive, so a type of stenosis or atrophy of the right ventricle and left ventricle. Okay, also fibrotic for those two ventricles. Okay, pericardium. There's pericardial effusion. This is where you get increased fluid in the pericardial sac. Remember the layers of the heart, there are 4 layers to the heart. The outsidemost layer is the pericardial sac. With increased fluid in the pericardial sac, you should know that normal fluid in that pericardial space is 30 to 50 milliliters. So if you are greater than 50 milliliters, example would be blood, pus, serous, fluid, then that's pericardial effusion. Okay, here's a picture of that. So here's the outside most layer to the heart. It's kind of like the heart is wrapped in a thin piece of leather. Okay, so that's the outside pericardium. If there's too much fluid buildup, okay, if there's too much fluid buildup, then you'll experience a cardiac tamponade. Okay, we'll get back to that in a second. But here are just a reminder of the 4 layers to the heart. The outsidemost layer is that pericardium, followed by a space, right? So pericardial cavity where you find the fluid. And then the epicardium, the myocardium, which is the muscle layer, and then the endocardium. Okay, cardiac tamponade is accumulation of pericardial fluid that causes heart compression or tamponade. Okay, the word tamp means pressure. Okay, so you're increasing the pressure here. Filling is impaired, meaning filling of the heart. Okay, the heart cannot expand properly, which means the ventricles are not going to be able to fill with blood very well. Okay, so filling is impaired. All right, signs and symptoms, there'll be a decrease in stroke volume and an increase in heart rate. The veins in the neck can be distended. Patient will experience chest pain and pulsus paradoxus. Okay, this is where blood pressure, right versus left arm, is greater than 10 millimeters of mercury difference. Okay, for example, normal blood pressure on the left arm, we'll say, is 110/76, and on their right arm it is 112/78. Okay, that is within the 10 millimeters of mercury. A positive finding example would be on the left side, 190/90, and on the right arm, 160/70. Okay, this exceeds the allowable 10 millimeters of mercury difference, right versus left arm. So this is called pulsus paradoxus. Okay, pericarditis, inflammation of the pericardium, presumed to be viral. Signs and symptoms: patient feels weak, an intolerance to exercise, and venous congestion. Okay, treatment can be anywhere from a pericardectomy to medications plus ionotropic to help with contractility. Okay, in the embryologic heart, 4 important heart developments are needed. Number 1, you need to develop the atrial septum. And then you also need to develop the ventricular septum. The tubes need to divide into the pulmonary artery and the aortic artery. Okay, this is collectively called the truncus arteriosus. Okay, by day 23, the heart begins to beat. Okay, so this is after conception. By day 23, about 3 weeks after conception. Okay, the most common heart disease in children is congenital. Okay, kids have not been alive long enough to really experience any heart issues because of diet and lifestyle stuff. So if a kid is going to have a heart issue, it's because it's congenital. Okay, shunts. So there is abnormal blood flow. Okay, this would be a right to left blood flow. We'll talk about that in a second. So signs and symptoms would be things like cyanosis, CO2 to oxygen ratios will be off. Left ventricle ejects low oxygenated blood. Okay, this right to left, let's draw this out. So here's the heart. Okay, you've got the right atrium and left atrium, right ventricle and left ventricle. Okay, let's grab the eraser. And if there is a hole, so that means things from the right side of the body are flowing to the left side. Okay, so that's considered a right to left flow, which means you're mixing deoxygenated blood with oxygenated blood. Now on the right side of the heart, that is going to be your deoxygenated blood. On the left side of the heart, that's going to be your oxygenated blood. Okay, and you don't want those to mix. So if there's a right to left mixing, then that means the in this case the deoxygenated blood is mixing with oxygenated blood, which means this person is going to pump deoxygenated blood into the aorta. Okay, so that's where this statement comes from: low oxygen levels in blood. Okay, another option is you can have a left to right mix. Okay, so it can go the other way where the left mixes with the right. So we just simply reverse these arrows. Okay, so if there's a left to right mixing, okay, a left to right mixing, then oxygen is going to mix with deoxygenated blood, or CO2, and oxygenated oxygenated blood is going to go to the lungs. From the right ventricle. Okay, no cyanosis, but right but the right side of the heart has an increased workload. So you're going to get right ventricle hypertrophy. Okay, in infant, a sign and symptom would be poor feeding, not thriving, tachypnea, tachycardia, gallop heart sound. Okay, another condition is atrial septal defect. That's a hole in the wall between the right and left atria. Okay, if that happens, if there's a hole, it is usually a left to right flow. Okay, and that has to do with the pressure. There's more pressure on that left side, so it would win and push fluid over to the right. Okay, I'm going to redo this because I drew it in the ventricle. So let's redo that. Okay, left to right. There we go. Okay, next is ventricular septal defect. Okay, so essentially it's the same thing, but to draw this correctly, you would put a hole in the ventricular wall. Okay, so that first one should be a septal wall, and this one is a hole in the ventricular wall. So, thus, the statement ventricular septal defect. Okay, it's usually a left to right flow because the pressure on the left side is greater than on the right. All right, patent ductus arteriosus. Okay, in a patent ductus arteriosus in utero, there's a tube that connects a pulmonary artery to the aorta. This way, the blood bypasses the lungs. All right, so in utero, the baby is not breathing using the lungs like we do outside of the womb. The placenta is doing the breathing, essentially. Okay, so this oxygenated versus deoxygenated blood then goes from the pulmonary artery to the aorta. Here's a picture of the patent ductus arteriosus. So in a baby, they have this extra tube. Okay, right here, the ductus arteriosus. After birth and by month 3, it should go away. Okay, so that tube should close and turn into what's called the ligamentum arteriosus. Okay, it is abnormal for it to not turn into this ligament. All right, so here is the ligament arteriosum in after the 3rd month. So the tube, the ductus arteriosus tube, as you can see here, should go away. Okay, if it doesn't, that's a problem. So if the tube remains, then you get a mixture of oxygenated and deoxygenated blood, and it is surgery to fix this, and usually very successful. Coarctation of the aorta is where you get a narrowing of the aortic tube. Okay, so the tube is the diameter is supposed to be nice and open and remain nice and open, but the tube narrows. So that is called coarctation of the aorta, where the aorta narrows. If we were to draw that out, there's your heart. Okay, there's the aorta. But it narrows. All right, signs and symptoms. It increases blood pressure in the upper extremity and will decrease blood pressure in the lower extremity. You'll hear a murmur and the person risks getting left ventricular hypertrophy because it is hard to push blood from that left ventricle into a kinked tube. So it has to work harder. Okay, the tetralogy of Fallot has 4 features. Okay, it gets its name from a French doc named Dr. Fallot. Okay, in the 1880s. Okay, this was coined by Dr. Fallot. But the first surgical repair was 1954. Okay, a little bit of history there. But what is it? Okay, well, it's 4 things. Number 1, it's a ventricular septal defect. Number 2, aorta at septum opening. Okay, number 3, these are in no particular order. Pulmonary stenosis, which obstructs the right ventricle. And then number 4, right ventricular hypertrophy. Okay, and then here is a picture of that. Your ventricular septal defect, so a big hole in the septum, narrowing or stenosis of the pulmonary valve. Okay, there's also pulmonary stenosis right there. So that's your pulmonary trunk is stenosing. And right ventricular hypertrophy. Okay, signs and symptoms: cyanosis, poor weight gain, heart murmur, and the baby does not seem to be thriving. Diagnosis is ultrasound, in utero can detect, or if it was missed in utero, then it would be observed postpartum via ultrasound. Pulse ox would be low and auscultation would be positive. Okay, treatment is open heart surgery. Those who survive, the survival rate is pretty high and seem to live normal, healthy lives. And some may need more than one surgery. A famous person that has this is Shaun White, who is an Olympian who has won many gold medals for snowboarding. He was actually born with the tetralogy of Fallot and clearly is doing really well.